Good evening, dear colleagues, and welcome to the webinar Soft Tissue Management in the Aesthetic Zone. My name is Brenda Brandley. I am from Dental Campus and your host this evening. The presentation will last about 40 to 45 minutes and be followed by a question and answer session of about 15 minutes. Please send us your questions. You may therefore type in the question in the window on your screen. After the presentation, Dr. Thoma will answer the questions. We'll do our best to answer as much as possible. If the time should not be enough, we're going to post the remaining questions in the forum of Dental Campus. The access is free. This webinar is going to be recorded and you will receive a link to replay it. I have now the pleasure to introduce you to today's presenter, private docent Dr. Thoma. He is faculty member and head of academic unit of the Clinic for Fixed and Removable Prosthodontics at University of Zurich. He has published numerous scientific articles in the field of soft tissue regeneration and lectures nationally and internationally on the topic. So, welcome, Dr. Thoma. The word is yours.
Good evening and welcome, dear colleagues. So I'd like to give you a brief outline of our lecture for the next half an hour. We're going to cover a few questions. First of all, we're going to ask, why do we need soft tissue augmentation surgeries in implant dentistry? And what evidence is available for the different techniques to enhance the soft tissue quality and the soft tissue quantity? And we'll then go more into a detailed clinical procedures for the two types of surgeries. And at the end, we're going to summarize and draw some conclusions before we go to the question and answers. So why do we need soft tissue augmentation surgeries in implant dentistry? Well, first, we need to ask which therapeutic means are state-of-the-art and which parameters define whether there is a need for a soft tissue optimization. And tonight we're only going to focus on keratinized tissue and soft tissue volume. So looking at some parameters, this includes the mucosal biotype, this includes the width of keratinized tissue around dental implants, and the soft tissue volume around dental implants. So let me start with the mucosal biotype. Well, what is important to know is that there is a thick and a thin biotype. So percentages always depend a bit on the publication you're looking at. But it's from a quite famous publication by Evans and Chen, looking at the aesthetic outcomes of immediate implant placement, that they concluded that the thin biotype carries more aesthetic risks and more often leads to recessions. So what about the width of keratinized tissue around dental implants? So again, we do have two questions. First, can the width of keratinized mucosa influence the peri-implant health? And if yes, so is there a threshold value that has been defined in the literature? Well, we could now go through a bunch of publications, and here are just some of the most recent systematic reviews on these topics. So I'm going to summarize that. Again, looking at the two questions, well, can the width of keratinized mucosa influence peri-implant health? If we rely on the more recent clinical studies that were performed, yes. And is there a threshold value? Obviously, it's somewhere around 2 millimeters of keratinized mucosa. So what about the soft tissue volume around dental implants? Again, a couple of questions. How much soft tissue volume do we need from a biologic point of view? Second question, is hard tissue augmentation sufficient when we place dental implants in the aesthetic zone in order to get an optimal outcome? And how much does soft tissue augmentation contribute to a final optimal volume? And last but not least, how much soft tissue do we need for aesthetic purposes? So we start with the biologic aspect. We're going to look at the systematic review by Akjali and a group of Nikos. The aim to determine whether soft tissue biotype at implant placement has an influence on crestal bone loss at 1 year after implant loading. Well, they included quite a lot of publications, but finally in the systematic reviews they included 6 studies, all controlled clinical studies that met the inclusion criteria. And 4 out of 6 individual studies compared the two types of biotype, thin versus thick. So the outcomes clearly show that there is significant higher crestal bone loss reported around dental implants in conjunction with a thin biotype. However, they could not define a threshold value based on this meta-analysis. Next question, is hard tissue augmentation sufficient in the aesthetic zone? So let's go to another publication by Jan Kozin. Well, the aims of this clinical trial were to document soft tissue aspects using a specific protocol for median implant placement. And then they also looked at the pink aesthetics. We're looking at materials and methods. They included 22 patients, all of them with a thick gingival biotype and an intact buccal bone wall upon extraction of a single tooth in the aesthetic zone, all of them in the maxilla. They then performed flapless extraction and implant surgery, so obviously immediate implant placement. They grafted the sockets, had immediate non-occlusal loading, and 6 months later, a final crown was inserted. So we have different time points up to 12 months. It's quite interesting that at 3 months post-implant placement, 5 of the cases demonstrated major alveolar process remodeling and 2 advanced midfacial recession. Hence, slight initial decline in the pink aesthetic score was observed. So would they perform this? In 7 cases, they treated them with a connective tissue graft. And this resulted in a steady improvement of the aesthetic outcomes as measured by the pink aesthetic score. So in conclusion, preservation of pink aesthetics is possible following immediate implant placement. However, to achieve that, connective tissue grafts may be necessary in 1/3 of the patients. And major alveolar process remodeling is the main reason for additional treatment. And these outcomes basically are supported by 2 other studies at least that show from an aesthetic point of view better outcomes in conjunction with the use of connective tissue grafts compared to untreated controls. Third question, how much does soft tissue augmentation contribute to a final volume? I'd like to show you a clinical study. It's a case series by Dave Schneider. The aim to evaluate the volume changes at the buccal aspect of implant sites over a period of 12 months. So basically they included 16 patients, all with a missing tooth in the aesthetic zone. And then they analyzed the volume changes due to hard and soft tissue augmentation surgeries, including a 1-year loading period after the insertion of the final reconstruction. It's very interesting that they found that based on the volume analysis and considering that when the final crown was inserted, this was considered as 100% of the volume, the GBR contributed to about 60% of the volume, and very interestingly, about 40% were regenerated by soft tissue grafting. So it was concluded that hard and soft tissue grafting were effective in augmenting peri-implant tissue volume, and it more or less remained stable within 1 year of loading. And we have seen that the GBR procedure contributed slightly more than the soft tissue grafting procedure. And last question, how much soft tissue do we need for aesthetic purposes? I'd like to show you another clinical study published in 2008 by Yoon. They evaluated the influence of the abutment material and the soft tissue thickness on the aesthetic outcome. They included 30 patients, all of them had implants in the aesthetic zone. They were randomly assigned to 2 groups, an all-ceramic abutment group and a metal ceramic abutment group. Moreover, soft tissue augmentation was performed in case there was less than 2 mm of peri-implant soft tissue thickness. So let's go through the outcomes. The outcomes were measured from an aesthetic point of view using a specific device, a spectrophotometer, comparing the implant site with the contralateral tooth site. Now we're looking at the results. You can see in red that's the all-ceramic group, and in green that's the PFM or metal-based group. Then you see N19, that's the group with grafting, and N11, that's the group without receiving connective tissue grafts. So looking at some numbers, it's very interesting to see that there was a difference between the all-ceramic and PFM group if no grafting was performed. However, if grafting was performed, there was no difference between the two types of reconstructions. So they could conclude that the thickening of the mucosa by soft tissue augmentation reduced the color differences independent of the chosen reconstruction material. And further on, there was a threshold value calculated, which was around 2, and this was also shown in a couple of subsequent studies. So looking at the indication, why do we need soft tissue augmentation procedures? We'd like to have thick soft tissues in order to minimize the risk for recessions. We'd like to have 2 mm of keratinized mucosa and a soft tissue thickness on the buccal side of about 2 mm. Now let's look for some evidence that is available for the different techniques to enhance the soft tissue quality and quantity, and we're also looking more in detail for the clinical procedures. So how do you get the information? Obviously the easiest way to do it is you look at some systematic reviews. So I'd like to summarize 2 of these reviews dealing with soft tissue grafting procedures. What you could show is that the procedure that was most often performed was the use of autogenous grafts. And one of the options is the use of a free gingival graft in order to increase the width of keratinized tissue. Usually in the clinic this is performed preoperatively. Preoperatively at this stage means that we perform these procedures prior to implant placement. So we're looking at the clinical procedure. It always starts with the preparation at the recipient site, so the area where we want to augment the keratinized tissue. We then go and harvest the autogenous grafts of the donor side. And finally, we would augment the transplant at the recipient site. So we're having a closer look at one of the cases. What you can see here, there is a missing lower central incisor. There is a very minimal width of keratinized tissue. So the procedure that was most often reported in the literature, we're going to prepare an apical apposition flap, thereby exposing the recipient area and exposing the periosteum. Next step, we would harvest an autogenous graft from the palate, and you can see the thickness is between 1 and 1.5 millimeters, so it's not quite a very thick tissue. And then we will go back to the recipient side and suture the transplant, the autogenous free gingival graft in the recipient side. It's always important that we try to have about 2 or 3 millimeters of distance between the apical part of the graft and the coronal part of the apical apposition flap in order that the transplanted area stays immobilized. And here we can see the further healing. That's at 1 week. We can see already very nicely healed even at the palate, where we actually have a spontaneous healing and open wound. And we see the same situation in comparison left 3 months after treatment to the right side prior to treatment, and we can see there is a significant increase in width of keratinized tissue. So looking at the results of the systematic reviews, it's important to remember that an apical apposition flap alone is a successful treatment concept to increase the width of keratinized tissue. But it has also been shown that when we add autogenous tissue like a free gingival graft, this can significantly increase the width of keratinized tissue. And the numbers we get, they range between 2.2 and 3.3 millimeters. So this is the science behind this procedure. But then of course you might ask, now we performed the procedure, we get a certain amount of keratinized tissue, what about long-term stability? Well, if I pick a couple of studies, and here you can see a couple of studies where they increase the width of keratinized tissue and have follow-up times ranging between 1 year and up to 8 years. It's quite interesting to see that there is a decrease in the dimension of the keratinized tissue, which ranges between 40 and 50%. So we lose about 50% of our width of keratinized tissue over time. Second option that we have, again, we can use autogenous tissue, but this time we're going to augment the soft tissue volume. And for that purpose, we'd use a connective tissue graft. Clinically, looking at the timeline in implant dentistry, this is usually performed during the healing phase of implant placement. So which means we place our dental implants, maybe do some GBR, we have further healing phase, and during this healing phase, we will do our soft tissue volume augmentation. Again, we look at the traditional clinical procedure, which starts with the preparation at the recipient site. We harvest an autogenous graft from the donor side, and then we have the augmentation and suturing at the recipient side, and last but not least, the suturing at the donor side. So let's go a bit more into detail. Here we have a clinical case where you can see an implant was placed. Well, you can see that, but you have to believe me. There was GBR performed, and you can clearly see there is a concavity, there is a volume deficiency on the buccal side. So traditional procedure would raise a full thickness flap on top of the implant, would then prepare a split thickness on the buccal side. And at lower right you can see that we're going to use a very sharp blade in order to do some releasing incisions within the periosteum, because we need to provide enough mobility of the flap. So we use quite a lot of these releasing incisions, and in the next slide you can see the differences prior to do the releasing incisions. On the lower right you can see after releasing incisions. So we provide a lot of volume, a lot of room for the connective tissue graft, and at the end we're going to have a tension-free wound healing. And then of course we need to harvest an autogenous graft. So usually what we're going to do is a single incision, and then we need to harvest the autogenous graft. It might be a little difficult procedure, so it needs some training. And of course there's always this fear that it's going to bleed. Usually we have quite a lot of bleeding once we try to harvest the autogenous graft. And here we can see we have harvested an autogenous connective tissue graft. Main difference compared to the free gingival graft is that we don't have any epithelial tissue. So it only consists of connective tissue, maybe some adipocytes, and maybe some glandular cells. So now we need to go back to our recipient side. So we place our connective tissue graft on the buccal side within the pouch, maybe also a bit on the crestal area, covering the implant. And then we need to suture our graft towards the palatal area. It's quite important that we don't use a lot of sutures for our graft. However, we want to have one suture, and it's a horizontal mattress suture, which immobilizes the grafts towards the palatal area. And then we're going to do a horizontal mattress suture, which closes and adapts the wound margin and takes all the pressure from during the healing phase. And the lower right you can see now we have two sutures. We have one knot and one suture to immobilize the graft towards the palatal side. And we have a horizontal mattress suture that adapted the wound margins. And now we only need a couple of single interrupted sutures to close the wound. Now we would usually have a healing period of about 6 to 8 weeks before we continue with abutment connection. So what about the evidence? Well, if you go to the 2 systematic reviews, well, this is based on 3 studies around teeth and 11 studies around dental implants, would have statistically significantly greater gain in soft tissue volume for connective tissue grafts compared to control groups. So how much volume do you get? Well, based on the studies, you would get between 1.7 and 3.2 millimeters. That's an increase in thickness. And we have already seen before that whenever we use connective tissue grafts, specifically in combination with the immediate implants, we get better outcomes compared to non-grafted sites. And again, we can ask, what do we know about long-term stability? So once we have augmented the volume, well, unfortunately, there is not much literature. So I'd like to therefore show you a clinical study with the aim to evaluate the volumetric changes in pontic sites with or without soft tissue grafting. And we're going to include a follow-up of 5 years. Unfortunately, we don't have data for dental implants. But basically, the study included pontic sites. You can see 2 abutment teeth that were prepared to receive a fixed dental prosthesis. And we were augmenting the pontic sites. You can see on the right-hand side, that's after pontic sites, after grafting, after a certain healing time. Further follow-up, we would do some soft tissue conditioning using provisional reconstructions, and then we would finally insert our final reconstruction. And this time point was considered as baseline. And then we have a 5-year follow-up. So all the patients were recalled 5 years later, and then we can measure the volume changes between baseline and the 5-year follow-up. So we have 2 time points, the insertion considered as baseline and the 5-year follow-up. At both time points we took impressions, we digitized the impressions, and then you can see on the right-hand side that's a superimposition of the models or of the casts. And based on these digital files, we're able to do some volume measurements. Now basically what we have a test group. So in 12 of the clinical cases, we performed soft tissue grafting. And then we also had a control group. And in this control group, no grafting procedures were performed. So it's a controlled study, it's not randomized, but we can observe the differences between grafted and non-grafted sites. And it was very interesting to see that over a period of 5 years, pontic sites grafted with a connective tissue graft, they showed a high dimensional stability. And there was also no difference compared to the control group. So whether or not we're going to augment pontic site with graft doesn't really matter in the long run. We get the same stability. And we did not lose much volume. But of course, whenever we use autogenous tissue, which is considered as the gold standard, what we have just seen, we always need to be aware that the greatest disadvantage is due to the second surgical site. And we also know from quite interesting publications dealing with soft tissue substitutes and the use of autogenous grafts, they concluded that the donor site was responsible for more than 50% of the bleeding and more than 70% of the swelling. So clearly we can see that whenever we use autogenous grafts, there's a clear disadvantage. So let's just look at one of the patients. What we can see here, that's a similar area. So we have a central incisor that is missing. We have placed our dental implant, performed GBR, and we have a buccal volume deficiency. So traditionally, what would we go and do? Of course, would do some soft tissue grafting. The problem is,
the palatal aspect
somehow I need to sell her this procedure. And we already know that this procedure is associated with major disadvantages. We already know that she's going to experience quite a lot of morbidity. And that's a major problem. So the other question would therefore be, if we can do something else, is there a possibility that we can use a soft tissue substitute, which would be the other option? Well, if you're interested in learning more about soft tissue substitute, you're welcome to join the soft tissue management online course. So at this stage, I'd like to, for the first moment, to thank you very much for your kind attention, and I'm very happy to receive questions that you may have had during the lectures.
So, very informative. Thank you so much. So, very informative presentation, Dr. Thoma. Thank you so much, therefore. So, let's go further to the questions. Would you give antibiotics when you graft?
Well, that's a good question. The problem is that we don't really know whether or not there is a need for the use of antibiotics. So just in order to be on the safe side, we'll probably give antibiotics, because whenever we use autogenous graft, being it bone grafts or autogenous soft tissue graft, it might be good to give the patient antibiotics for the period of about 7 to 10 days.
Can you use ethos instead of a graft? One user asked.
I'm not really familiar with this kind of materials. I'm very sorry, I cannot answer this question. I know that there are some soft tissue substitutes available, and there is quite good evidence that we have for soft tissue grafts and for soft tissue substitutes and the use of for keratinized tissue. Unfortunately, there are no devices available on the market to be used for soft tissue volume grafting.
Okay, perhaps a user who asked this question could give some more information so that we could
Would certainly be happy to answer this question. It's just important to know that for soft tissue substitutes, we can only use them for keratinized tissue and currently not for soft tissue volume.
That would be great. So if you're the participant, write something more if you would like to know more. Then what when the package does not stay?
Well, as far as I understand that, that's probably something about the stability of the augmented sites, I could imagine. Well, I think it's quite important that when we do volume grafting, and I think the question probably relates to that we really have a tension-free wound closure. That's probably one of the most important aspects. And in order to get that, we always need a couple of releasing incisions within the prepared pouch. And then, of course, it always starts to bleed. We basically have prepared quite a lot of room for our graft. And then it's important that we use a horizontal mattress suture in order to immobilize the entire area and to adapt the wound margin. I think these are the two critical aspects.
Okay. So how long do you wait after implant placement until you graft, and why?
Well, if this relates to soft tissue volume grafting, this really depends on whether or not we perform the GBR procedure. So I would say in the best case, if we have a certain healing period with a dental implant without GBR, we'll probably go and graft the area after a healing period of about 6 weeks. If we have an extensive GBR procedures with resorbent membrane, we'll probably wait for about 3 months prior to go for soft tissue grafting. Of course, if you're going to use non-resorbent membrane, then might be a good time point to go for soft tissue grafting at the time when we remove the non-resorbent membrane. So we usually have a healing period of about 6 months.
Okay. One question is, what suturing material do you use?
I don't think it really matters the type of suture material. I think it's more the way we use the suture material. So I don't really have a preference for a specific suture material. I think it's just important that we always go for relatively thin suture materials when we deal with keratinized tissue, because the tissue is relatively thin. When we go for soft tissue volume grafting, I think it's just important that we have our horizontal mattress sutures. But I don't think it's important that we use a specific suture material.
Good to know. Does the type of implant abutment connection influence soft tissue outcome?
Well, basically the way we do perform soft tissue abutment connection certainly influences the outcome. So in the aesthetic zone, and we do also have a lecture on the online. In the aesthetic zone, would usually go for a U-shaped flap, a rolled flap, which gives us another bit of more volume towards the buccal side. So certainly this does influence. And certainly it's always important that whenever we graft the site, we don't want to reduce the width of keratinized tissue or the volume we grafted previously. So this certainly matters quite a lot.
Okay. Now, A general question. Which is the best site to harvest the graft?
Well, the best site, I think there are different ways to understand this question. I think one option is that we have easy access. So easy access, as we have also seen it in the clinical cases, is always the palatal area in the region of the two bicuspids and the first molar. However, there we obviously have sometimes quite a lot of bleeding. Also, the tissue quality may not be the same. So from a tissue perspective on the density of the connective tissue, which would be ideal for soft tissue volume grafting, tuberosities area would be preferred. But quite often the patients would not have any tissue there or not enough. So most often we'll go to the palate.
Okay. Then another question. Could PRF be used for soft tissue augmentation as a graft material and membrane to avoid second surgical site?
I think PRF has been used quite extensively for quite a lot of these procedures. If the question is can it be used, probably it can be used. There is just not enough documentation to give any recommendations, but I'm pretty sure that when we go for gain of keratinized tissue, basically any resorbable device with or without a combination of the PRF could be used to augment keratinized tissue.
Mm-hmm. Do you do GBR and skin care grafting at the same tissue?
Probably the question relates on whether or not we can do everything during a single surgery. So basically, especially when we deal with immediate implants, typically in the aesthetic zone would perform GBR and the soft tissue grafting at the same time. If we're delaying everything and go step by step, then we'll probably go first for GBR, wait for a certain period, and then just evaluate whether or not there is a need for further soft tissue grafting. So obviously, would then continue with soft tissue grafting after a certain healing period, following implant placement and GBR.
Okay.
So I can see that we do really have quite a lot of questions.
Yeah, it's a really interesting topic. We'll just go further in a second. I'll take this.
Waiting for some questions.
Can we use soft tissue laser on the donor side to stop bleeding?
Well, the issue with the donor side is always the bleeding. That's certainly something we have also seen. Personally, I don't use laser or anything like that. I just use a sterile gauze and do quite a lot of compression. And we should not be really worried about the donor side, even though there might be some bleeding. We can use some local anesthetics and the compression with the gauze. And we should not be worried about doing the suturing to stop the bleeding initially, because we do care more about the recipient side. Mm-hmm. So whenever we do soft tissue grafting, we should first focus on the recipient side. At a later stage, usually once we have applied compression, then it stops bleeding and we can just do a regular suture. So if there is a need for using laser, there might be a need. I don't think there is really an issue with it.
So SCTG versus gingival graft, which one will provide more thickness after healing of recipient side to augment a horizontal defect?
Well, the free gingival graft and the connective tissue basically have two different indications. So whenever we use the free gingival graft, we will include the epithelium, which means we're going for an open healing. Of course, we can increase the thickness of the free gingival graft, but the idea is not really to increase the volume, rather than to gain keratinized tissue. So when we do augment volume, we use a connective tissue graft without epithelium, and we would submerge it, so there is no open healing or only very limited. So two totally different clinical indications.
Okay. One last question would be, to augment a horizontal defect, what is by your preference? Any indication for first hard tissue grafts than soft tissue grafts?
That's always a good question. I think a typical example is that you might want to have a Pontic site where you're later going to use a fixed dental prosthesis. So if we have minor defects, which I would say is probably about less than 2 millimeter or 2 millimeter max grafting, but certainly I would always go for soft tissue grafting. And just in case we have a huge defect, also use in addition some hard tissue grafting.
Okay, great. So the remaining answers will be posted in the Dental Campus forum, and you'll receive a link to the record of the webinar. Dental Campus is an e-learning platform for implant dentistry. We provide a wide offer of high-quality continuing education in the field of implant dentistry, and we would like to recommend you Dr. Thoma's extensive course in soft tissue management in implant dentistry on our platform. As a thank you for your attendance in this webinar, we would like to offer you this week a 20% discount on the course. You will receive a link to use this offer. And feel free to visit our website and register, for example, for a free account. So, on behalf of all participants, I would like to thank you very much for your great contribution, Dr. Thoma. And to all participants, thank you so much for your attention, and I wish you a pleasant evening.
Thank you very much.
Thank you.